you for this important webinar on obesity. I'm Professor Herath. I'm attached to the Faculty of Medicine, University of Unagol. Obesity is one of the important diseases that we have to deal as internal medicine specialists. So obesity can lead to various other complications such as diabetes mellitus and dyslipidemia and fatty liver. Therefore, we all have to know how to manage a patient with obesity very well. So as Sri Lanka College of Internal Medicine, we believe in continuing medical education and also believes that empowering and educating our membership on various important diseases are of paramount importance. We will conduct series of webinars and other teaching activities, teaching and learning activities. And this webinar is one of such things that we conduct for the benefit of our membership. So we are going to cover three important topics during the webinar today. The first topic is on facts and myths about obesity. Obesity is such a common disease, therefore there are so many myths associated with obesity, and some of these myths are so deep and so intense that it has already penetrated among our specialists and our doctors also. Dr. KVC Janaka is going to talk to us and enlighten on various facts and myths about obesity. Dr. KVC Janaka is a consultant physician attached to the Sri Javadarapa Hospital. Then managing obesity, we all know managing obesity, but of course our involvement can be quite patchy. We just look at only one aspect of obesity. So, but looking at a patient with obesity as a whole and managing every aspect of obesity is very important. So it is. So therefore, Dr. Nirmala Jayasinghe is going to talk to us on managing obesity in real world, physician perspective, and she will tell us what to do, basically covering all the aspects of obesity. We can't forget about surgery. Surgery is such an important aspect of management of obesity. Dr. Praveen Raj, who is joining us from India, he's going to talk. Raj is one of the consultant physician, and he is the head of the Department of Minimal Access Bariatric Surgery in GEM Hospital and Research Center, Coimbatore, India. Without much ado, I would like to invite our first speaker, Dr. KVC Janaka, to talk to us on obesity, facts and myths. Over to you, Dr. Janaka.
Good evening. I hope all you can hear me well. First of all, I would thank Herath and the Society of College of Internal Medicine for giving me this opportunity. Actually, I will be deviating slightly from the topic that I have been given, and I will be discussing about 2 or 3 concepts related to obesity. Mainly, I will be discussing about the genetics behind the obesity, and something about the obesity paradox, which is a concept that we have to know, and something related to healthy obesity. I think this should cover the time that I have been allocated, so I can't discuss more than that. So first of all, I didn't prepare a presentation as such, but I would discuss through the slides I have. Now, when you take obesity, we know that obesity is prevalent. Can you see the slides? Okay.
Yes, we can see. Yeah, we can see.
So obesity is a highly prevalent medical condition. Like 1.9 billion adults all over the world are overweight, and 650 adults were obese in 2016. And we know that about 39% of the adults over the age of 18 are overweight, and overall 13% of the world's adult population were obese in 2016. It varies from country to country. The world prevalence of obesity has tripled between 2000 1975 to 2016. How about Sri Lanka? I took data from two studies conducted by Katulanda and Noel. The first I'll go through the Noel study done in an urban setting. Now, in urban setting, when we used the international cutoff values, it is alarming. The overweight and obesity prevalence was 37% and 15%, 15.8%. When you use the Asian cutoffs, it is 34 and 31%. So it's very alarmingly high. And the community prevalence of abdominal obesity was 58%. So more than half of us are abdominally obese. Now, when you take overall in Sri Lanka, but this was done in 2010, 10 years back, the overall obesity was, overweight was 25% and obesity was 26% respectively. When you take the Asian cutoffs, 16 and 3.7. In the, sorry, when you take Caucasian cutoffs, 16 and 3.7. This is in 2010. Now, this is the prevalence. Now, I'm not going to talk about how we diagnose obesity or the cutoffs values and things like that, which is very common knowledge. But I have got two concepts, which is called obesity paradox. Now, people have seen, now this is a chart from one of the articles regarding obesity paradox, the ICU admissions and the mortality. Several studies they have seen. Now, when you take the BMI of 25 and it goes up, when it goes to overweight and obese range, actually the ICU mortality drops, right? This is seen in the ICU mortality. This is seen in after stroke. This is seen after cardiac surgery. This is seen after myocardial infarction. So it's a well-known finding that overweight people have a better prognosis or better mortality reduction after an acute event. It goes off when they are morbid obesity. When they are morbidly obese, it's again it goes. I mean, the mortality is high, but between the normal weight and overweight is doing better. This has been seen throughout all over. I mean, mainly the cardiovascular events, ICU, surgery, so all these things. So there have been a lot of hypotheses going on regarding why this obesity paradox is there. When the weight is low, there's high mortality. When the weight is high, less mortality. This is short term. You have to understand this is not lifelong mortality. This is a disease outcome. Now, people believe that this is because actually this is seen more in the elderly population, right? When you look at these slides, BMI and the mortality rates, right, after an acute event, in the younger age group, this is the lower line, right? This red line at the lower end is the younger age group, and the blue line is the elderly age group. With the age, it is parabolic. Like you see that high mortality with the lower BMI and slightly better mortality when they are overweight, and again mortality goes up. But in the younger age group, it is linear. With the increasing obesity, the mortality is high. So they believe in this elderly population, their obesity is slightly different from that of a younger man. Young obese, they think that they have more visceral fat and less muscle. But in older obese people, they have relative, you have relatively more muscles and relatively less visceral fat compared to a same patient, same younger patient of the same BMI. So that is one reason that they think that this obesity paradox exists. Therefore, with the increase in muscle mass, they have a higher resistance or insulin sensitivity. Then other things is that they have general fitness to undergo an acute stress. So there are a lot of theories behind that, but no proven reason that is always harmful. It has some benefits, especially in an acute event. Then I'll go to the next concept that I want to talk about. That is the healthy obesity. Healthy obesity, right? Healthy obesity. Then now we know people who are not obese are healthy. Now when you look at this size, normal body weight person, they have normal weight, normal muscle mass, normal insulin sensitivity, so they are healthy. But then there is a group of people who are metabolically healthy but obese. They are called metabolically healthy obese. And there's another group which they are called metabolically unhealthy obese. Now, how would you define metabolically healthy obese? They are obese by the BMI, but they have normal pressure, normal sugar, triglyceride less than 150, and normal HDL. So they don't have the metabolic syndrome. So they are called metabolically healthy obese people. We see a lot of these people on and off. However, this metabolically healthy obesity is not a static thing. They can transform into a metabolically unhealthy obese patient if their lifestyle change. In the other way, even a metabolically unhealthy obese patient can get themselves transferred back to a metabolically healthy obese patient by involving in lifestyle and lifestyle modification, diet and exercise. So metabolically healthy obesity is a transient phenomenon which we see. So even and other important thing is, now this is the same thing, but other important thing is when you compare a normal weight metabolically healthy person with an obese metabolically healthy patient, the obese metabolically healthy patient has increased risk of heart disease, increased risk of cardiovascular disease, and increased risk of heart failure. So they are transiently healthy. They are healthy during that period only, but their future risk, life risk is high if they maintain their obesity. So this is the two concepts that I wanted to explain. Then I will touch, because this will help my next speakers to talk about the obesity management. This is a complex slide. Don't worry about this, but I will give you some concepts. We know the lower down, the adipose tissue. Adipose tissue is the one that produces the hormone called leptin, right? So this leptin act on the leptin receptors at the hypothalamus, or arcuate nucleus of the hypothalamus. Then we have insulin that also act on the hypothalamus. But the most important hormones when you consider weight is the leptin, and the other important hormone is the ghrelin, secreted by the stomach. Leptin is the satiety hormone. When you have high leptin, it reduces the desire to, it reduces the food intake. When you have high ghrelin, ghrelin increases food intake. So leptin and ghrelin act in an antagonized manner. Leptin is produced from the adipocytes, and the ghrelin is produced from the stomach. When a person is obese or having a lot of fat cells, they have high leptin levels. So when the leptin levels are high, they stimulate the production of a hormone called pro-opiomelanocortin from the hypothalamus, which is broken down into alpha MSH and ACTH also. This alpha MSH acts on receptor called MC4R receptor. So action of alpha MSH on MC4 receptor will inhibit food intake. So that is the pathway that we have to know. So increasing in leptin will increase pro-opiomelanocortin. Increased pro-opiomelanocortin will be broken down to increase alpha MSH. Alpha MSH will act on the MC4R gene receptor, and it will inhibit the food intake. On the other hand, ghrelin will, in a different pathway, act on the same receptor and increase food intake. So if we have a leptin deficiency, people will become obese because they issue with this hormone, they eat more. If there's an issue with alpha message, they eat more. Or if there's a defect in this receptor, again, they eat more and they become obese. This is the genetics. So because of that, there are now obesity has a lot of factors. Lifestyle, that is why over the period of obesity has increased. In addition, there are a lot of genetical factors. Obesity is mainly polygenic. However, there are few monogenic diseases also involving the leptin receptor, pro-opiomelanocortin, and MC4R receptor. So these are the commonest genetic disorders, and from these, the MC4R receptor gene mutations are the commonest genetic cause of obesity. So this is the concepts that I want to explain. And in treatment, my colleagues will discuss melanin. Leptin can be used when there's leptin deficiency in genetically defective people who don't have leptin producing gene, which is autosomal recessive gene. Levels are very low and they have high insulin resistance. You can give leptin and you can improve their insulin resistance. I will stop my talk here and I will hand over to my colleagues to continue with their speeches.
Good evening, ladies and gentlemen, professors, senior consultants, and my dear colleagues. I hope that you can hear me. My concise talk today will be principally based on plain and simple weight management in obesity, and I will touch on all the aspects regarding the weight management in obesity. So, how are we going to manage an obese patient? If you need a single, none other than adaptation of a healthy lifestyle. Very simple. And whatever the strategies that you are using, the most important principle behind it should be achieving a caloric deficit. And management of obesity, the cornerstone of managing obesity is always a partnership between a highly motivated patient and a committed team of health professionals. We should always set realistic goals when it comes to obesity management. We usually look at the end of 3 months and 6 months where we expect to have 5% and 10% reduction of initial body weight, respectively. And the rate of weekly weight reduction is shown in the screen here. There are 5 main components for obesity management, including diet, exercise, medications, behavioral changes, and surgery. Quickly moving into diets. Although there are lots and lots of diets available for weight management, there are 2 main types of diets. One is consistent weight designed to give either a low calorie version of it or a portion control version of it. And these types of diets are widely used for obesity management. The second type is diets with different macronutrient components. Whatever the diet is used, all diets promote healthy whole foods, including whole grains, processed foods, sodas, fruit juices, and limiting alcohol to a minimum. Let's talk about low calorie or portion control diets. These are designed to give you about 800 to 1800 kilocalories per day, aiming at loss of about half a kilo per week. And if you're really careful, this can lead to about 1 kilo per week weight loss in some cases. Moving on to diets with deficiencies, the most widely rather, I would say, maybe more efficacious if we look at the 6 months endpoint, where it produces more weight loss than the low-fat diet. And low carbohydrate diet is also associated with favorable changes in cardiovascular risk factors. When we look at the endpoint at 1 year and even longer, because all diets. So in practical point of view, we should try and find out what suits your patient, what type of diet suits your patient. But at the same time, you should be careful in finding the practical version of the diet you're choosing for the patient, whether the patient can continue practicing that diet for life, because long-term weight management will depend on the compliance of the patient with the diet. And a few words on very low calorie diets. They are designed to give you extra weight loss in a short period of time. These are not recommended for long-term weight loss because the compliance will be very, very poor. These diets give you less than 800 kilocalories or less per day. And it is associated with lots of metabolic benefits, but short-term. These are used in subsets of patients, in special situations, such as very obese type 2 diabetes patients, where you need a metabolic improvement quickly in them. And it is best used as a stopgap measure before bariatric surgery to make the surgical field more visible for the surgeons. So that is how are you going to prescribe eating for your patient. And you can prescribe not eating to the patient also, that is fasting. Fasting has become fashionable in weight management nowadays, particularly intermittent fasting, where 16 hours fasting a day is usually recommended. But if you look at the practical point of view here, you can even rather go for 14 hours fasting or 12 hours fasting for your patients. And it will augment the weight loss results, because in the literature, you can see lots of studies backing up fasting for its benefits in health, aging, to the regime. And it is better if you can introduce resistant training once your patient achieve their aerobic goal. And resistant training in particular may be beneficial in type 2 diabetes, where it can increase the insulin sensitivity. So it has been shown repeatedly in studies that when you combine exercise with diet, the benefit is more. And the patient will have benefit of sustained weight loss for the long term. And exercise alone is not very useful in weight loss. So what if that your patient is too lazy or too busy? There are two other alternatives that you can try on. One is high intensity interval training, where we can incorporate brief high intensity activity for a short period of time, alternating with normal paced activity. For example, if you are running, during a given minute, the first 30 seconds, you run as fast as and as hard as you can. And the rest of the 30 minutes, what you do is you run in the normal pace. And you can do it for as short as 3 minutes, and you can do it as short as 5 minutes. But it will also give the same benefits of moderate intensity exercise. It has been shown repeatedly on the studies, the efficacy of HIIT. And moving on to NEAT, which is non-exercise activity thermogenesis, whether your patient is doing exercise or not, every patient should be encouraged to increase their NEAT in day-to-day life. NEAT is increasing low-grade activity throughout the day, being active throughout the day. You should encourage patients to walk more, to be standing more, to be fidgeting, to be doing household work, cleaning, gardening, etc. And you should always discourage them being in a seated position for long, and also the screening time. And there are lots of studies showing the benefits of increasing NEAT in a lifestyle. And actually, this can burn up to 2,000 extra calories in a given day. So moving on to pills and injections, it is always an adjunctive part of weight management. You should incorporate it only into lifestyle changes. And you can choose medications for people who are very obese and who have obesity related comorbidities. And what is widely used here is orlistat, which is a lipase inhibitor. And some studies have shown that when it is combined with L-carnitine, the effect is more. And there are 2 combinations available to combat appetite. This is widely available in Europe and also in US, not in Sri Lanka up to now. And moving into injectable, this is liraglutide, which is a GLP-1 analog, we all know that, and we can use in severely obese patients, specifically if the patient is a diabetic, we can use it as a replacement for insulin. Gradually, we can introduce liraglutide in place of insulin. I'm not going to talk to you about, there are so many newcomers in the field of managing obesity, including melanocortin 4 agonist, peptide YY used as an inhaler, leptin. Those are used in only subsets of patients, not widely used still, but. And moving on to psychological therapy, this gets the spotlight in weight management now. Because when you talk about weight management, you are talking about lifestyle changes in a person. To change the lifestyle, you have to change the habits of that patient. Habit changing is not very easy. You have to change the thinking pattern of that person. You have to change the psychology of that patient, and you have to change the behavior of that patient. So this psychological therapy is a very important part in managing an obese patient. This also includes screening your patient for a major psychological disorder like major depression, and also screen them for major eating disorder and referring them for professional psychiatric support. Also, this includes giving the psychological support and behavioral support as a physician during their journey of weight loss. And it has been shown consistently for sustained weight loss, behavior modification is essential. And stress management and sleep management is also necessary part in behavioral modification, because repeatedly it has been shown sleep deprivation and stress is associated with weight gain. So we know there are lots of strategies we can try on, but why it is so difficult to have sustained weight loss? Because these obese patients are on a continuous struggle, both internally and externally. Internally, because they are fighting against the adaptation going on inside their bodies, both hormonally and neurally. Also, 50% of weight variance is determined by the environment the patient is in, their family environment, so the society, the working environment. Everything plays a role in the weight management. So let's look at what determines the successful weight loss. These studies have shown what determines a successful weight loss is being consistent with a healthy eating pattern for long. Being consistent with being active throughout the day and not being inactive throughout the day for long. And it is the self-efficient patient who can self-monitor, who can take educated decisions regarding diet and exercise are the most successful in weight loss. And if your patient is able to maintain their lost weight for more than 2 years, they have a higher chance of maintaining that for life. So some studies have shown if you can introduce a culturally adapted weight loss program, the success may be more. And also if you can enroll your patient in the multidisciplinary team and a program, the success may be more. So what are the key factors here? We should cultivate long-term, practical, sustainable, healthy dietary changes in our patients. We should be able to cultivate long-term, practical, and sustainable active lifestyle in our patients. And we should be able to educate and give behavioral feedback for them to be self-efficacious, to be monitoring and be motivated, and to have good lifestyle choices throughout long term. And we should be there as physicians correctly and consistently with our professional guidance. So what are the challenges we face here? We should get our patients motivated. We should know how motivated our patients are and the reasons for their motivation, and can they sustain this motivation long term. And it is always a challenge to provide affordable, practical, healthy long-term lifestyle choices, because we have to consider everything in this patient, including the family environment, the society, the working environment. And it should always be a dynamic process, not a static thing. The final decision should be a result of ongoing discussions with the patient. And we should design something that the patient can stick into for the life. So the next challenge is how committed that we can be as physicians to manage these patients. Long-term commitment is needed. And inevitably, the limiting factor here will be the time in a setup like us. And we have to do all these things in a so-called obesogenic environment that we live in, which promotes obesity rather than weight loss all the time. But is it very difficult and too difficult all the time? But you can see there are lots of successful weight loss stories out there, because it is actually easy when it comes to professional, experienced, and committed hands. I repeat, when it comes to professional, committed, and experienced hands. The problem here is we see now the weight management is mostly done by is in the unprofessional hands. So who are these professional, experienced, and committed hands? They are going to be you. So it is the time for us to be committed for our patients. Start a dialogue with our patient. And we have the knowledge now. And we should formulate individualized plans for each and every patient to go through this journey, which can be successful one day. Thank you for listening to me. And I'm privileged to have this opportunity to have this talk here. And I should specifically thank Professor H.M.M. Herath for giving this opportunity to me. Thank you very much.
Thank you, Nilwala, for that interesting lecture on the obesity management. Before we move to the next lecture, I just want to ask from the audience to use the chat and Q&A icon to send your questions. If you have any question related to the topics, please send your questions. Then we can divide time. So with that, we will move to the next lecture, which is going to be delivered by Dr. Praveen Raj. Over to Dr. Raj.
Yeah, hi, good evening, friends. And I'd like to thank the organizing committee for having this specialized focus talk on obesity. And I think it was interesting talks from Dr. Janaka and Dr. Nilwala. And I think I would continue on with it from the science of obesity to the non-surgical management of obesity. I would be talking on bariatric surgery and what is the role? Is it the gold standard? So I will share my screen. Yeah, so I think you'll be getting my screens. So my topic will be on bariatric surgery. Is it the gold standard? So before even I get into the topic, first I bring you greetings from India to all my friends in Sri Lanka. And see, bariatric surgery, although what the title says, is it the gold standard? It is not competitive to the other non-surgical measures like your dietary management, exercises, medications, but it is more complementary to the other methodologies that we have actually spoken about. So bariatric surgery cannot work alone. It is primarily for patients who have attempted weight loss measures or who are unable to attempt weight loss measures, as mentioned by Dr. Nelvala. So that is where bariatric surgery comes to complement these methodologies and not separately. So it is not competitive, but complementary to the other measures of weight loss. So with this basic background, I will move on. Whenever I talk to physicians, I always feel like standing in front of a crowd of lions where we talk about diabetes and obesity, the science behind it. I am actually a surgeon, but then, however, considering the theme of the conference, I wouldn't dwell deep into the surgical aspects, but more into the scientific aspects of obesity. I think the biggest myth that has been broken in the last few years is the belief that obesity is a disease and just not about increased caloric intake or reduced energy expenditure, as still many of our medical colleagues still believe. So I think it is a duty of every physician or every specialist involved in obesity is to take the message to the masses. I mean to say the medical community and also the non-medical community that obesity is a disease which is linked to a lot of neuronal signals, gut hormones, and gut microbiota, which interact in a complex way to actually cause an abnormal energy homeostasis that actually causes obesity. So treatment of obesity just doesn't sometimes help by basic dietary measures, because there is a pathophysiological mechanism that needs to be understood, that needs to be corrected by whatever methodologies that we have in practice. So with that understanding, now we know obesity is closely linked to the other metabolic disorders, what we call the metabolic syndrome. And the word metabolic surgery, or because bariatric surgery is now more commonly or more preferably called the metabolic surgery, because it is intended to correct the underlying metabolic abnormality. So hence, by not just correcting obesity, but the other metabolic disorders like your dyslipidemia, diabetes, hypertension, etc., and also the other factors like the polycystic ovarian disease, non-alcoholic fatty liver disease, etc. But interestingly, this word metabolic surgery was first coined in the year 1978 by this person called Buchwald, or Henry Buchwald, who actually coined this word for the first time, where he said any operative manipulation of a normal organ or an organ system to achieve a biological result for a potential health gain, anything where you operate on a normal organ to change an underlying pathophysiology, hence by you correct it, is called metabolic surgery. So that's exactly what we're trying to do. In bariatric, we would be operating on anatomically normal organs. It could be the stomach or the intestines, where we try to modulate to get a change, which I'll be talking to you about. Hence, we try to give. So that is the concept of metabolic surgery. It doesn't just mean correction of metabolic syndrome, but correction of any medical disease which can correct metabolically. So I would try to go to certain myths and how scientifically the facts to these myths will be given. So I would break this myth is the way I've designed this presentation. So first of all, many physicians or many medicos around the world still believe that bariatric surgery is a new specialty, is a recent specialty that's been there in the last few years. So is it really good? Do we have long-term data? Is the question that we always have. But if you go back to literature, the first bariatric surgery was actually published in the year 1954, when this guy called A.J. Kremen was actually doing an experimental evaluation on dogs to understand the physiology of small intestines. So he was trying to play around the intestines, trying to give bypass, to remove, trying to make the different geometrics with it. When he understood that bypass of certain portions of the intestine can actually produce weight loss without actually causing hazardous effects or impairments. So he brought out the concept, yes. So by playing around the intestines, we can possibly treat morbid obesity. And he went on to do one surgery and went on to publish. This I'm talking the year 1954. So the birth of bariatric is as early as 1950s. So in fact, the curve started to raise. I think with coronas, we've been used to talking to curves, etc. So the curve started to raise as early as 1960s, with around 1970s, 80s having actually a very good peak, which continued to grow on and on and on and on until now. Of course, many different changes have happened over the years. But bariatric surgery is close to a 70-year history. It is not a new specialty. It's been there around the world for many, many years. It's just that it came into the Asia in the maybe the late 1980s or the early 1990s, and into India in 1998. I'm not sure about Sri Lanka. I think somewhere in late 2000. I mean around 2010 onwards, if I'm right, but correct me if I'm wrong. So that is the history of bariatric. It is not a new specialty. It's been there for a long time. The second myth is we all believe bariatric surgery works by making somebody eat less and by causing this bypass, hence by causing a malabsorption. So basically, it is believed that the restriction and malabsorption is how a bariatric surgery really works. So these are the two commonly done operations. One on the left is called the sleeve gastrectomy, where we make a tube like a stomach. The second one on the right is called a gastric bypass, where we make a small gastric pouch. We bypass a small portion of the intestine, like in a road, when there is a kind of the road work happens, you have a bypass, we try to bypass. So looking at this picture, you'd be able to say that, yeah, probably the first one, you're making somebody eat less. In the second one, you're making somebody eat less, plus also you're causing a bypass. So restriction and malabsorption. Yes, on the face of it, anatomically, yes, that is what we do. And that also happens. So there is restriction and there is malabsorption. However, that is not the primary means it works, but surgery by causing certain hormonal modulations actually causes anorexia. We induce hormonal anorexia and also increase the energy expenditure rate by playing around with many hormones, but the hormones that we know based on evidence are ghrelin, peptide YY, leptin, and oxyntomodulin. So by playing around with these hormones, we are able to cause anorexia and increase energy expenditure. So let's go into one of the first hormone, which is ghrelin. Ghrelin is all the orexigenic hormone or an appetite hormone. So that's responsible for appetite. That is produced in the fundus of your stomach, or the top portion of the stomach is what you call. Either of these procedures, this fundus is either removed or it is excluded. So the levels of this ghrelin drop down. So the appetite of a patient comes down, causing a kind of anorexia. The second hormone is called peptide YY. So this is produced in the L cells of the ileum, where this GLP-1 is also produced. I think Dr. Nelwala spoke to you about the liraglutide, which is a GLP-1 analog. So the same cell that produces GLP-1 also produces peptide YY. This is basically an anorectic hormone that is intended to cause anorexia. However, the levels of this are dysregulated in obesity, so that many of these obese patients have an uncontrolled or they do not experience anorexia until they eat to a particular point. But post-bariatric surgery, the levels of these hormones elevate, so causing an early anorexia or early satiety. When I come to satiety, the more important hormone where we talk about satiety is leptin. See, leptin is basically produced in the fat or the visceral fat. It is a satiety factor. So more the fat, more should be the satiety. Less the fat, less leptin, less should be the satiety. However, obese people, many of the obese people have leptin resistance, so they don't experience satiety. And this leptin resistance is closely related to insulin resistance also. What happens post-bariatric is, because of reduction in the visceral fat inflammation, because there is always a chronic low-grade inflammation of visceral fat in obese people, especially so when they have metabolic syndrome, which gets corrected post-bariatric surgery. Hence why leptin resistance drops, insulin resistance also drops. Hence by moving in the overall metabolic syndrome and diabetes, which will come to it a little later. And fourth, there's this hormone called oxyntomodulin, which is also produced by the L cells in the ileum, which increases the basal metabolic rate. So when you're bypassing the intestines, the L cells produce the nutrition exposes to the L cells much earlier than what it used to be. So GLP-1 gets elevated, peptide YY gets elevated, oxyntomodulin gets elevated. Because of GLP, diabetic improvement happens, which I'll explain to you in a few slides from now. Peptide YY causes anorexia, oxytocin increases the basal metabolic rate. So by reducing appetite, increasing anorexia, achieving satiety earlier and increasing basal metabolic rate, we are able to give and induce an anorexia energy expenditure rate. That's also one of the important reasons how bariatric surgery works, along with causing restriction and increasing malabsorption. However, why I'm saying restriction is not so much important, because we tend to give nutrition or the caloric needs to meet the actual needs of the patient in a more split portions. So they tend to take almost 80% of the nutrition that they're already taking. So the intent is not really to make them eat less, because most of the obese patients actually already were eating less. Unlike what we used to believe, that most obese patients are actually binging. No, more than 80% of the patients you see in your clinic wouldn't be actually binging. And also today, bariatric surgery also has another wing that's developing very rapidly called endobariatrics, where we do the procedures endoscopically without actually having to do a surgery. Many different procedures are coming in the market, but of course, the two common or the two approved and commonly done ones, or my personal experience, are the intragastric balloons. This works only by restriction, causing early satiety. This is primarily intended for people who are hyperphagic, who are not able to control, maybe for adolescents obesity, or in patients who are unfit to undergo bariatric procedure. The second procedure that has become quite popular in the recent times, 2 or 3 of the centers in India, we have started doing this. It's called the endoscopic sleeve gastroplasty. Similar to the sleeve gastrectomy you saw earlier, wherein we make a tube kind of a stomach, we basically stitch from within using an endoscopic device called the Apollo Endo Stitch, where we stitch the stomach using plication, and we make a narrow stomach. That's called an endoscopic sleeve gastroplasty. So these are for intermediary set of patients wherein your diets and medications aren't working, or probably they aren't too big enough, or probably the metabolic syndrome isn't bad enough that they really need a warrant a bariatric surgery. So the intermediary group or the outliers group, this balloon or the endoscopic sleeve gastroplasty have a big role to play. The third myth is diabetes. If you take the first line in any medical book, would be diabetes is a progressive disease. So from what it starts, it continues to progress forever. Hence the need for medications, the need for insulins continues to become increase and increase. Interestingly, when this bariatric surgery were done in the 1960s and the 70s, it was primarily done with the intent of obesity. However, in the early 90s, this guy called Walter Porys tried to retrospectively analyze the patients he had operated for obesity. And when he looked into the data, he found that a significant number of patients who were operated for obesity who also had their diabetes completely going away. So he was actually not sure how the whole thing has happened. So that's how he wrote this paper called, or the landmark paper where we titled it, Who Would Have Thought It? An operation proving to be the most effective therapy for adult onset diabetes. At that point of time, they did not really know how the whole thing were happening, because they were doing the Roux-en-Y gastric bypass, wherein they were bypassing the duodenum and the proximal jejunum, which we call the foregut. They thought, he along with his medical colleague called Matthew Hickey, they called a new paradigm for type 2 diabetes. Probably could it be a disease of the foregut? Until then, predominant of the research were focused towards insulin production and insulin resistance. I think from there on, the entire spectrum moved towards the gut. And now, billions of dollars are being invested to understand the gut hormones and medications behind gut hormones. And now we have moved towards microbiota, etc. It was from here that the gut took attention as an endocrine organ in the pathophysiology of diabetes. And in fact, many of the authors tried to do a meta-analysis and review of papers and found that 80 to 98% of the patients who were operated for bariatric surgery in the long term had their diabetes completely going away. So this progressive nature, they were able to come back to a baseline. So it was just not progressive. You were able to cause remission of diabetes. To understand this, I think we need to understand the incretin effect. I think most of you watching this lecture would know much better than me of the early phase of insulin secretion and the late phase of the insulin secretion. As you know, the early phase of insulin secretion is mediated by this hormone called GIP, or the glucose-dependent insulinotrophic polypeptide produced by the K cell in the duodenum. So this is the first phase of insulin secretion, where it is at the duodenal level. Then the second phase of insulin secretion is what is mediated by GLP-1, which causes a surge in insulin secretion again. But if you look into the pathophysiology of diabetes, it has been noted that this first phase of insulin secretion is suppressed by certain anti-incretin factors against these incretins, that this GIP is actually having a resistance. So this production and its effects on the beta cells is suppressed, causing an hyperglycemic effect. In bariatric, because we bypass this foregut, we are avoiding the stimulation of the cells, which is producing this unknown factor causing this anti-incretin effect. Hence why we are bypassing this whole thing away from the duodenum. And this concept or this hypothesis is called foregut hypothesis, where you bypass food from going into the duodenum where there are certain anti-incretin factors. Simultaneously, as you bypass, you are making your food reach the terminal ileum much quicker than what used to happen, so that you stimulate the L cells, which were producing this GLP-1. If you remember back, this is the same cell that were also producing the oxyntomodulin and peptide YY. So because the nutrition is reaching the terminal ileum faster, you get supraphysiological levels of almost 5 to 10 times GLP-1 levels elevate in your blood. And you know you as physicians out there, you know the effects of GLP-1. It's trophic to the beta cells of pancreas, reduces hepatic glucose output, etc. And it is based on this concept. Nowadays, we have this GLP-1 analogs and the GLP-1 agonists in the market, which is trying to mimic GLP-1 role. And that's how you also get some weight loss in these drugs too. So this concept of getting the nutrition to the ileum faster is called the hindgut hypothesis. It is through this combination of foregut and the hindgut hypothesis that we are able to control diabetes, or the whole component of metabolic syndrome. And in 2011, the American Diabetology Association came together to actually, can we create a concept of diabetes cure? And they actually, in this consensus statement, they actually mentioned a line that if you can maintain remission of diabetes for 5 years, it is called long-term remission, which can operationally be called cure. Although diabetic cure is a very controversial terminology, but yes, these were the statements from the American Diabetology Association. And of course, in the standards of guidelines from the 2017 onwards, metabolic surgery has been included as a treatment of diabetes from 30 BMI onwards for the West and 27.5 BMI onwards for Asians, because you know the difference of YY paradox, how Asians are different in terms of our fat percentages. I think let me not dwell deep into that. That is this difference in the BMI cutoffs for the West and the Asians as such. And this is one of our papers where we have published a few years back, where we looked into the lipid profiles and also the cardiovascular risk profile post-bariatric surgery. We were able to see a significant improvement in the lipid profiles and also the cardiovascular risk. And this is another study where we actually did a histopathological analysis of non-alcoholic fatty liver disease, which is the hepatic manifestation of metabolic syndrome. We also saw significant improvement of all grades of NAFLD after surgically induced weight loss. And again, on polycystic ovarian disease, which is the reproductive component of metabolic syndrome, also have significant changes post-bariatric. This is again from a center published a year back. So science, surgery is an art, but bariatric surgery is science. We need to work very closely with endocrinologists, for the medical colleagues, to understand where we would play a better role, not just in the treatment of obesity, but the entire components of metabolic syndrome, so that we can treat the patient much better, not just in the short term, but in the long term. So the comparing the indications together, now various different guidelines have come over the years, but over the years, what has really happened is, if I just put all these guidelines together, if I really need to understand for Asians, maybe for Indians and Sri Lankans put together, any patient more than 35 BMI trying weight loss measures and is unable to lose weight is an indication for bariatric surgery. And any patient above 30 BMI with obesity related comorbidities is an indication for bariatric surgery, and more than 27 may be considered with poorly controlled diabetes. This poorly controlled diabetes needs to come from the endocrinologist. But I think on a practical sense, anybody who's compliant, proper medical therapy for 6 months, if you're still unable to achieve the standard HbA1c levels, maybe we can consider them for a bariatric surgery. So this is, I wouldn't call it bariatric, probably the metabolic surgery. It's a better terminology to use, because the intent is just not weight loss, but to correction of the metabolic comorbidities. So these are a couple of our books that we have published from our institute with regard to bariatric and metabolic surgery. So to coming to the conclusion, the intestine is the largest endocrine organ of the body. Metabolic syndrome is a result of a complex interaction of the intestine, adipose tissue, and pancreas, where the gut hormones and the microbiota, etc. Bariatric surgery is just not about restriction of food intake or the malabsorption that we all believe. And by knowing this physiology of the intestines and the pathophysiology of the disease, if we can manipulate the small intestines appropriately, we can achieve beneficial metabolic effects. And that's why we popularly call it metabolic surgery. Thank you all for your patient listening.
Thank you, Dr. Raj, for the interesting, very comprehensive lecture on the surgical aspect of obesity. In fact, we have several questions. I would like to ask the first question from Dr. Raj. Apart from the indication that you just mentioned, like a BMI cutoff, what are the other? Are there any other contraindication? For example, not being compliant to the diet and exercise. Is it one of the contraindications for bariatric surgery?
No, I mean, as I just mentioned, I just rushed through. So the indications, all the guidelines have clearly mentioned this point. It's just not based on the BMI criteria. Of course, after the BMI criteria, there are two important statements every guideline has. That is, the patient needs to be motivated for weight loss. The patients need to have attempted some kind of weight loss measures in terms of diet or a supervised weight loss measures, either if the patient is unable to do for practical reasons like osteoarthritis or intervertebral disc prolapse, etc., or the patient is genuinely attempted, is unable to lose weight, that is when bariatric surgery itself is indicated. So when we have an unmotivated patient, it is a contraindication. It's a relative contraindication.
Right. Okay. So there are a couple of other questions. The next just mentioned that the obesity is just an imbalance between energy intake and energy expenditure. Do you agree with that?
So the question is to me?
No, to Dr. Nilvala Jayasinghe. The question is, obviously, just simply the imbalance between energy intake and energy. Is it true?
It's partly true, actually, because the obesity management lies largely on creating a calorie deficit in patients. So it's largely true, but there are so much of other factors combined together. But the end result is actually more calories being deposited than what is being used.
Right. Okay. The next question goes to Dr. Janaka. And of course, sometimes the patient says that I'm obese just because my family members, all the other family members are obese. If a patient says to you like that, will be your? Do you think that is correct? So what is your?
Yeah, I think, I mean, genetics plays a major role in obesity. Some families, people are obese. It may be it's the genetics, or maybe the family environment. Some families, they eat more, or maybe the social environment. So it's always multifactorial. But things like MC4 gene mutations it's relatively common, but maybe genetics, maybe their behavior, the family behavior, or the environment. So it's always multifactorial. You just can't accept we have to accept if all the family members are like genetically, like if the previous generation is like that, then probably there is some genetic involvement is there. So genetics as well as the other things, lifestyle and the social things. But always overweight, whatever it is genetics or not, overweight is, obesity and overweight is, it has a risk compared to a normal weight person.
Right. Okay. Correct? I think the next question goes to Dr. Nilvala. Hello, can you hear me?
Yes, I can hear you.
The next question goes to Dr. Nilvala Jayasinghe. The question is about the intermittent fasting and how effective the intermittent fasting is.
I think in my talk I have shown a few studies on that. Actually, intermittent fasting is effective as an augmentation to the diet you are using. What is usually recommended is 16 hours fasting. And I pointed out that if you are practical enough, you can either go for 12 hours fasting or 14 hours fasting throughout the 24 hours period. If you want, I can share the slides again for them to see, because I talked about intermittent fasting during my talk, and it is effective.
So when a patient goes for intermittent fasting, yeah. the question is, when a patient goes for intermittent, increase the fat intake and reducing carbohydrate, or just normal diet and increase fasting space?
No, fasting should be used as an adjunct to the diet that you're using. You have to use some kind of diet in these patients. And adjunct to that, you can introduce fasting window for such patients. And there are some instances where you can do fasting in a different way. Not during the 24 hours. You can fast for 2 days for given week. And during that time, you're not taking anything caloric during the 24 hours. And rest of the days, you're allowed to eat. But again, you should go for healthy eating always. Is that the answer that you have expected?
Yeah, sort of. Yeah. No, the people talked about this ketotic diet. Of course, by increase the fat intake, you change the energy source from carbohydrate to basic ketone bodies.
Yes.
And some believe that with fasting, if you increase fat, you can produce more ketone in your body, so that you can change the energy, the source also. That is the question.
Right. If you are using intermittent fasting, I think it is better for you to go for a low-fat diet. But still, I couldn't find any research to say that you shouldn't do low carbohydrate diets with intermittent fasting. There are no studies to point out that. But if you are talking about going, zero carbohydrate, like very low carbohydrate diet, that is less than 10% of carbohydrates in your diet, that may cause high ketone bodies in a given patient. But if you are just doing less than 25% or less than 20% of carbohydrates in your diet, that is also called a low carbohydrate diet. That I think will be fine with intermittent fasting.
Okay, I think the next question also goes to Dr. Nirvala Jayasinghe. How practically we can recommend calorie restriction to patient? How to decide on calories in available food? Should it be with the help of dietitian always? I think there are 3 questions in that question. The first one is how practically we recommend calorie restriction?
Yeah. So
Hello.
Yeah, it is a very good question actually. I think we should take this in our clinical setup, where we are pressed with the time, that we don't have time to assess all the diets in a patient and assess the caloric intake and give a diet to the patient. It's true. In the ideal setup, what you should do is, at least you should go for a 24-hour recall of a dietary intake of a given patient and assess the dietary intake of that patient and reduce that calorie intake from about 500 to 1000 from the initial intake to design a diet. That is the ideal way, and you can get the help of a dietitian for that. But grossly speaking, you can advise your patients giving general advice, like when you take your plate, you should restrict your carbohydrate to 1/5 or 1/4 of the plate. And you should fill up your plate 3/4 of your plate with green veggies. And you can use proteins and protein sources the way that you are using, like 1/4 of the plate. That is the crude measurement that you can tell your patients to apply. And the principle you should tell them is to restrict on the high calorie dense food, like fried food, fast food, avoid fruit juices, avoid sodas, avoid alcohol, and go for green veggies all the time. Fill up your plate with green veggies, and your plate should look like a green thing, not filled with starch. And you should reduce the starch content to 1/5 or 1/4 of the plate. So that kind of general advice you can adopt in your clinic setup. That's what I usually do. It's my personal experience that I'm talking about. But in ideal setup, you should go for at least a 24-hour recall of a patient's diet and design a diet according to the initial intake of the calories of a patient.
Yeah, like
Right,
what Nirmala suggested, I think we should first ask the patient to, when you go to the table, first take vegetables, then protein, then put the carbohydrate into the plate, rather than putting rice first. That will reduce, automatically it will reduce the rice intake.
What I gave was an example of low carbohydrate, high fiber diet. So if that can be adapted to patients. Now the problem is to adapt these kinds of things in a busy clinic setup. So we should come with attractive and simple instructions like that. But in ideal setup, you should go through the patient's diet carefully and design a diet with calorie counting.
The next question that I would like to ask from Dr. Praveen Raj. Now, what is the place of doing the surgery in a patient with normal weight, but of course metabolically obese, which means the patient has all the parameters of metabolic obesity, but of course the patient's BMI is normal. What is the place of surgery in that sort of patient?
So it's an interesting question. See, when we look into the current guidelines, guidelines are based on strong level 1 data, level 1 evidence that's based on the guidelines. As we look at the guidelines, any BMI above 27 with the intent of control of diabetes is already indicated. I mean, most of the guidelines, the medical association guidelines have also endorsed it. Now, the question is anything lesser than that. I think we do have a literature from 18 BMI onwards for the treatment of diabetes as such. However, without existing guidelines, these have to be very selectively done under the context of a clinical trial. In fact, I have done my doctorate a few years back for the treatment of diabetes between 25 to 30 BMI, not just anything as 27, 25 to 30 was my research. And yet we were able to see significant, I mean, earlier, I mean, the thesis paper was not really be accepted. There are a lot of ethical issues. Then finally, we had to subject it to get it clearance. Although we do have data on the normal BMI, at the present point, maybe at centers where they are doing it on a clinical research basis. I mean, we do have a clinical research team. It can be done, but not on a regular day-to-day setting. It is at present not recommended.
Okay. The next question again goes to you. Now, how long will it take for the surgery? I mean, of course, there are 3 different types of surgery that you described. And general, roughly, how long will it take, you know, for one surgery? And also, what is the sort of complication rate, like mortality rate?
The surgery depends on the type of surgery. Sleeve gastrectomy takes about 30 minutes or so. The gastric bypass takes about 45 minutes to 1 hour. And there are, for the lower BMI, which we were just talking about, there are actually, in literature, there are 54 different types of surgeries that have been actually published. But however, 3 or 4 are the commonly done ones. 2 was the most commonly done one around the world. So these are the time interval as such. But with regard to the complication rates, these surgeries are as safe as any other gallbladder surgery. There was one review of literature where they tried to compare the mortality rate between a gallbladder surgery, what we call the cholecystectomy, along with the bariatric surgery. I think both had a similar 0.2% mortality rate of cholecystectomy and bariatric surgery. I mean, the conclusion was it was as safe as a cholecystectomy.
Right. Okay. I think the time which is I think almost over. So I wanted to thank all the 3 speakers for the excellent lectures and giving over various aspects of obesity. Especially, I want to thank Dr. Praveen Raj, who joined us from India. Thank you very much for your excellent lecture and giving the surgical aspect of obesity, which is quite not a familiar field for us as physicians. So thank you very much for that. And Dr. Janaka and as well Dr. Nilwala Jayasinghe, thank you very much for your contribution. And also want to thank all the participants who joined us. And I hope that what you learned here today will be useful for the management of your patients. Thank you very much for joining.